grateful that you could present for us today.
Hi, everybody. I will start with saying that I am homesick. Unfortunately, it's not COVID. I've already had that. So I apologize if I need to cough or take a little sip of water. Let me just share my screen. There we go. Let me go back to the beginning. Can everybody see that? Okay, let me just make it presentation mode. All right. Okay, so getting started, we are just going to talk about pediatric respiratory illness and the big three that we're seeing this year. Mostly, well, I mean, the big three that we see every year is bronchiolitis, croup, and asthma, and we will briefly talk about COVID-19 and where that fits into it. All of this information was either taken from the Canadian Pediatric Society, which what pediatricians are, their board exams are on. So this is all the information from there. They set out guidelines for Canada or the Interior Health websites. So definitions, this is a very tricky one because I find unless you work in a pediatric specific hospital, the gray area between neonate and pediatric is very blurred. And we do find that here in Kelowna General as well, because we have a NICU and we also have a pediatric ward and the physicians cross over for both. So technically the definition, neonate is a newborn to 1 month and a pediatric is 1 month to 17 years, or I guess 18 years minus a day. However, though, once a patient leaves the hospital, they are considered a pediatric, and if they come in with pediatric reasons, then they will be treated as such. So big resuscitation differences, this is just kind of very basic on PALS. So ventilation oxygenation is the most important. Your best friend in any situation is a bagger. So whenever you have a pediatric patient, it's very important to make sure that your bagger is set up and ready to go in case the child decompensates. You will have most of the time you will have success by just ventilating them. Compressions are 15 to 2 before signs of puberty. And then you do want to begin chest compressions for heart rate less than 60 and signs of poor perfusion. And that would be after 30 seconds of effective ventilation. So chest moving up and down with each ventilation. If they're still not improving, you would start chest compressions. Fluid boluses range from anywhere from 10 to 20 mils per kilo. New evidence is coming out saying to start on the lower end if it's just for basic resuscitation. If they're in active shock, maybe go on the higher side. And then a point of care glucose should be treated as a vital sign in pediatrics. They often have low glucoses due to their high metabolic demand. So just quick overview of assessment. Your first initial assessment should always be done outside of the room. When kids get upset and you go in and you start touching them and you start listening to them, there goes your very basic assessment. So it should always be done outside of the room. The three things you're looking for: appearance, breathing, and circulation. Biggest question to ask: is this child acting like a normal child? Are they crying appropriately? Are they not crying? Is that not good? If they're sleeping, we need to go and assess if they're actually sleeping or if they are unconscious. And then breathing. Question I ask myself: is this patient going to compensate? Are they able to continue this? Are they going to get tired from whatever they're doing? I took these two pictures from a BC Children's document, and I think it's really a good visualization of severity of work of breathing. And I don't know if this presentation is going to get sent out, but I'm happy to share the slides after. Kind of as a guide for somebody who doesn't see work of breathing in children often. Their chest cavities are very malleable because there's there's lots more cartilage as opposed to bone. So you do end up seeing work of breathing more pronounced in children. History, this is also a very important thing to note, and especially when we get into the respiratory components and respiratory illnesses, they essentially present the same. So we need to have really good history from the parents to figure out what's going on so we know how to do the treatment plan. So Any heart and stroke course will say sample history, so signs and symptoms, allergies, medications, past medical history, last meal, and events leading up to it. But really the big things you want to ask are they immunized? That helps rule out your differential diagnosis. Did they have a stay in the NICU, and how long was it? If they did, it's usually a sign that they're going to have severe respiratory disease and they might require an admission. What's the family history? Is there a family history of asthma? This will help differentiate if they have maybe bronchiolitis versus asthma to help guide your plan. And when did the symptoms start is also a very important question with differential diagnosis. Okay, so like I said, the ones that we're going to cover today are bronchiolitis, croup, and asthma, and then we'll touch quickly on COVID-19. So bronchiolitis. What is bronchiolitis? Bronchiolitis is a general term for really any virus that causes some sort of respiratory distress. It's the most common cause of admission for children less than 1 year old, and it's characterized by obstruction of small airways with acute inflammation. And what's really specific to it in the severe cases, it can cause necrosis of the epithelial lining. So that's not good, and they do present very sick. So as I said before, what causes it? The most common virus is RSV, which is what I hope I don't have, but probably have. Others are included, but not limited to rhinovirus, parainfluenza virus, human metapneumoinfluenzas, adenovirus, coronavirus, and bocavirus. And the reason that I wanted to highlight coronavirus, because I mean, COVID-19 is definitely a mutation of coronavirus, but prior to the COVID-19 pandemic, kids did present with bronchiolitis, and a big cause of it was coronavirus. So when kids are presenting to emergency with COVID-19, they do present essentially like a bronchiolitis, and you would treat them as a bronchiolitis. Co-infections with multiple viruses occurs in 10 to 30% of children. So if they do have two viruses, they often tend to have more severe illness. And they are the ones that sometimes will require escalation of therapy, so BiPAP, potential intubation. Signs and symptoms, very non-specific, anything that you would see with any sort of respiratory. Really, the biggest thing to diagnose this is obviously the signs and symptoms of respiratory distress, but really it's the preceding viral respiratory infection. So the upper airway, cough, rhinorrhea, then eventually as the disease progresses, it moves into the lower parts of the airway and causes the bronchiolitis. Another big question to ask is if they're sick at home. It's very often, oh yeah, we have a 2-year-old brother is in daycare and came home sick and gave it to the 6-month-old. That's a very common presentation of bronchiolitis and a very common history. And then signs and symptoms. So again, anything, tachypnea, intercostals, accessory muscle use, nasal flaring, grunting, color changes, wheezes or crackles. I do have to say that true bronchiolitis, it's more of a crackles when you listen to them. It kind of sounds like a popping sound when you listen to them, or as some say, the washing machine sounds. They do have decreased air entry to the bases sometimes. If you hear wheezes, it's more of a low-pitched wheeze, usually a secretion wheeze, not necessarily a high-pitched wheeze. But we will get into the combination bronchiolitic asthmatic picture and what to look for those. So anticipation is very key for these patients. Having an understanding of the clinical course of the virus will help determine if the child will worsen or not. So back in our history, we talked about when did symptoms start. RSV specifically has a very common trajectory, of course. Usually it peaks around day 3 to 5. So if someone comes in and you say, when did symptoms start? Oh, they started 2 days ago, and you've determined this patient looks quite sick, they're probably just going to get worse. If they came in at day 7 and parents said, you know, it's just been 7 days of this, it hasn't got any better, they're probably not going to get worse, and you might lower your spidey senses for this patient because they might not get that sick. However, we are finding that this season, because there is that that year of children who kind of missed the RSV, when they're coming in, it's tending to peak around day 7 to 10 at this point, and it tends to last a lot longer. And we're just noticing that this year. So it might be that, you know, the 1 to 2 year olds haven't really had that exposure of RSV yet. So management, this is where a lot of the evidence has changed over the last few years. So when I first started working in pediatrics, we did everything. We gave salbutamol, we gave hypertonic saline, saline nebs, chest physio, corticosteroids, antibiotics. Recent evidence has come out that it's really symptom management. There's not much that's going to help with it because it is a virus. The CPS does recommend oxygen therapy as needed for lower saturations. We'll get into the oxygen therapy in a little bit. Another big thing is hydration. So often when these kids come in, they haven't been eating well because they haven't been able to breathe very well. Maybe their nose has been stuffed up, so they're not breastfeeding, they're not orally feeding, or they just feel crummy, so they're not taking in as much fluids. These kids will often require some sort of supplemental hydration. Evidence, things that you can try depending on how bad the kid is. So the one thing that CPS is recommending is an epinephrine nebulization. Again, this would be you try it, it doesn't work, don't repeat it. Make sure it's documented really well. Nasal suctioning, you can do it before starting other therapies like oxygen, or if you're going to put an NG down, you can definitely try suctioning the nose, but it shouldn't be as a routine scheduled thing, just kind of an as needed thing. And then combined epinephrine and dexamethasone. So if the kid is really bad, or if you're suspecting some sort of reactive airway, you can consider doing a trial of dexamethasone or epinephrine and nebulization. Not recommended is definitely salbutamol, antibiotics, antivirals. Hypertonic saline is a big no-no. Up until recently, it was a very common practice, but 3% saline is very salty water, and it can actually cause more irritation into the lungs. So evidence, oxygen therapy. We always hear about high flow and low flow in these pediatric in the bronchiolitic patients. So really, if the kid is satting less than 90% or less than 88% for 3 minutes while sleeping, you can start them on a little bit of low flow. If they have minimal work of breathing specifically, so you don't want to, if they're satting anything lower than that and they have significant work of breathing, it might be beneficial to start them on high flow, which we will talk about high flow in a little bit. There has been some studies that have also shown that occasional dips into the high 80s or into the low 90s, as long as they recover, that's okay. Specifically with bronchiolitis, we don't necessarily need to start oxygen therapy. That it's just more if there is sustained desaturation. They often do desat when they're sleeping and when they're feeding, and as long as they're recovering on their own within a few minutes, that's okay. So inhaled medications, we've kind of already talked about that. So there's many studies comparing Ventolin, normal saline, hypertonic saline, and epinephrine. None showed more benefit over the other. CPS does recommend a trial of nebulized epinephrine. Another really big thing is supporting hydration. So most children requiring hospital admission will require supplemental hydration, either via NG or IV. Either or works. Generally, an NG is a bit easier to get, especially if they're quite dehydrated. They might be very difficult to get an IV on. So putting an NG is a very quick and easy way to start hydration. If the child has severe increased work of breathing, or if their respiratory rate is 60, or if they've been started on high flow, the patient should be NPO and an IV and NG should be placed. We are in the process of developing high flow and bronchiolytic PPOs currently within the health authority, and they are going to P&T next month. So hopefully they'll be ready to go live in the next few weeks, and all of this information is on there. So nasal suction. Previously, we used to always use the deep catheter and go down to the back of their throat and suction up as much as we can. That has actually been shown to increase hospitalization time and worsen nasal edema. So that practice should no longer be done. If you're going to suction the nose, because you can actively hear the nasal secretions and you can see them coming out of the nose, just use this little soft tip yonker here at the bottom. It's called the neosucker. You can use a couple drops of saline in each nair just before suctioning to kind of create a neti pot effect to help loosen up the secretions. And this ideally should be done before you're going to place them on airvo or high flow or oxygen or any sort of feeding. Sometimes just suctioning in the nose can really help with them, especially in that younger population. Okay, so what are you going to do if this patient comes in and they kind of are wheezing, they have a history of asthma, they're also bronchiolytic? Really, If they're less than 1 year old, it's probably not beneficial to give any sort of Ventolin or any sort of Atrovent. Their beta-2 receptors, which is what Ventolin works on, may not be fully developed yet and may not respond to Ventolin. So it's not ideal to give any sort of salbutamol to a less than 1 year old. However, and especially this year, we are seeing that 1 to 2 year old come in with the bronchiolitis and potentially have some high-pitched expiratory wheezes, some forced exhalation, family history of Ventolin. So what do we do then? If they're greater than 1, they do meet the criteria for the Pram score, which we will go over later on in this presentation, and you are able to Pram them. Generally, though, if you're giving the Ventolin and Atrovent or whatever they Pram at, if it's not working, there's no benefit to continue on doing it. It's not going to work. So if it's working, great, and the Pram score is improving, wonderful. But if it's not, it's just added therapy that they don't require. Okay, when to intervene. We know a lot of kids come in with RSV, and a lot of them might just need a little bit of Tylenol and off they go. But when do we determine that this patient might need to be admitted? So mild to moderate bronchiolitis is symptom management. Not all children need intervention. According to UpToDate, severe bronchiolitis is characterized as persistent increased respiratory rate with any work of breathing assessed by repeated examinations separated by at least 15 minutes. So the key with children is you might walk in, they're crying, they look horrible, but that's because we just upset them. We really need to step back and look at that kid when they're settled and determine if their symptoms are repeatable in each exam. It's also characterized by hypoxemia. So in children, generally, we have our red flags up if their SATs are less than 94%. We know that that's not normal in children to be less than 94%. In bronchiolitis specifically, we get concerned if their SATs are less than 92%. So if they're kind of on that in-between range of 90 to 92, you could definitely start with low flow first, unless their work of breathing is severe. Another characterization by severe bronchiolitis is apneas, which is often seen in the younger population, and they definitely need to be admitted for that. And then obviously acute respiratory failure. So if their LOC is deteriorating, we definitely need to intervene with that. The decision to admit. This, again, comes from the CPS guidelines. So if they're unable to maintain adequate hydration, so while they're in the emergency room, you definitely want to encourage the family to breastfeed, bottle feed, any sort of feeding possible. If they're unable to maintain that hydration, they're unable to feed, it could be a reason to admit. So risk of progression to severe disease, we kind of talked about that. If they require oxygen, they have a severe accessory muscle use, respiratory rate greater than 60, or apneas, or if they have any of those groups for high risk of severe disease, you can see at the bottom here. So infants born prematurely, less than 3 months of age, hemodynamically unstable, or immune deficiency, they're at high risk for severe disease. Family unable to cope, which is a totally fair admission. And then, as we said before, infant at high risk of severe disease. So that's bronchiolitis. The CPS guidelines do have a lot more information about when to swab, when to do chest x-rays, but for the most part, all of that stuff is, if they're mild to moderate, they don't need any more intervention. If they're severe and you think something else is going on, you might need to investigate further. Okay, croup. So croup is also something that we are seeing very common in the emerge right now. It is one of the most common causes of upper airway obstruction. It's generally caused by parainfluenza virus, which also can cause bronchiolitis, so they can potentially have croup and bronchiolitis all at once, which is super. I hope I'm not in that trend right now. It's generalized by airway inflammation and edema of the upper airways. It is subglottic, and that's why you get that barky cough and that change in their voice that they have. Severe croup is extremely rare, while it's definitely present, but it is less than 6% of all hospital admissions. So presentation of croup, once you've seen it, you know. So it's usually a rapid onset, including barky cough, inspiratory stridor, hoarseness, and respiratory distress. It's often seen in the middle of the night, and there is this theory that you have your natural corticosteroids, and in the middle of the night, they start to dip. And when you have less corticosteroids running through your body, you could potentially have more inflammation. So I remember working at Children's, and I would sit by triage, and at 3 a.m. you would always hear that barky cough come in, and you're like, oh yeah, at 3 a.m. it's about time they all start coming in. It often affects children between 6 months and 3 years, and symptoms usually last 3 to 7 days. Really, that the true giveaway of croup is that barky cough. Inspiratory stridor can be caused by lots of things, but the barky cough is a very, very clear indicator of croup. Differential diagnosis is, so there is quite a few. Bacterial tracheitis is definitely one of them. They're often febrile and often appear septic, and they do not respond to nebulized epi. You also have the risks of peritonsillar abscesses. Epiglottitis is something that we talk quite a bit about, and everyone thinks it happens often. I've seen it less than a handful of times in my career. Not that it's that long of a career, but it's something that you hear about and often not there. We are immunized for Haemophilus influenza, so that's again another really good point to ask the family if the immunizations are up to date, because that can potentially be a differential diagnosis if they're not. Foreign body aspiration, we know kids always put everything in their mouth, and then obviously anaphylaxis. Treatment for croup. So the goal is always oral steroids. Dexamethasone is what every kid that presents with croup will usually get when they come into the emerge. It takes about 4 hours to start working. So once they have it, we generally would like to monitor them for at least 4 hours, depending on how severe they are, maybe less than that. Epi is administered for moderate to severe croup. This is a Band-Aid though. It's only going to get you until the dexamethasone starts working. So really to give epi or not, we have to be a little bit concerned about their airway, because it's not going to do anything. It's just prolonging, it's just preventing the airway from closing and making sure that they're in a stable place until the steroids start working. So the Wesley Croup score was something that was approved to use in interior health 2 years ago. I can't exactly remember, but this just gives a guide of when to give epi, really. As you can see down at the bottom here, cyanosis and level of consciousness account for a large portion of the point. So if you have cyanosis or you have decreased level of consciousness, you have a very, very sick crouper. And at that point, they definitely need steroids, but they also definitely need epi. So once you get your score, it brings you to this diagnosis of croup, and it has this algorithm here. So you have mild, moderate, severe. Mild, they really just they all get steroids. Mild, you just monitor them. Moderate is when they have a Wesley Croup score of 5 to 10, and they could benefit from the Epi MDI. I'm not sure if every site has the Epi MDI, but again, that was a temporary approval, a non-formulary medication that was approved for the COVID-19 to prevent AGMPs of nebulized Epi. There is a link on this that we can send out later about the information from it, and if you're interested in getting it, I spoke with the peds pharmacist, and I guess there's information on this package on how to get it in your emergency department. I was just super skeptic about it. I didn't believe it was going to work, but it does. It does actually work quite well. So it's essentially epinephrine in an MDI form, and you give it the same way that you would give Atrovent or Ventolin epi, with the aero chamber and the mask on the face. The dose is 5 puffs, and you can repeat that every 3 times. I'm not going to get into the details of it, just because it is very clearly laid out in the package, but that is something that can be used for COVID-19 during the COVID-19 pandemic. My inclination to give epi or not give epi is if they have stridor at rest. To me, if they have stridor at rest, their airway is too small and they need help. If they have stridor when they're crying, maybe keep your spidey senses up and they might need a dose of it, but definitely if they're at rest, that's when I would start giving epi for stridor. So this just gets into a little bit more of the information about the epi MDI, and then down here is the link for the toolkit, which also gives all this information. I can't see if anybody's raising their hand with questions, so someone will tell me if there's a question. Is that right?
Yes, that is correct. We will moderate.
Okay, good. Okay, so that's Croup. Review of Croup, all get Dex. Not everybody gets Epi. If they have Strider at rest, you can consider giving an Epi. I will say too, if they have an oxygen requirement or decreased LOC, it's probably best to just go right to the NEBs. Epi MDI, the kid has to be a little bit cooperative in order to do it, even if that means that they're screaming, that's cooperative. If they're not screaming and they're super tuckered, then you definitely just want to go straight to NEBs. Or if they have an oxygen requirement, you want to go straight to NEBs hooked up to oxygen. Okay, so asthma review now. Biggest thing about asthma is, and the Pram specifically, so the Pram is a approved assessment score and management score to use within BC. It's also used, I believe, across Canada. It's a very well studied and very well documented form and how to determine how severe a kid is. However, it's only going to work if the kid meets the criteria, and that's super important. The criteria is they need to be greater than 1 year old. As we talked about earlier, less than 1 year old, they don't really respond well to Ventolin. They don't have those receptors developed enough. So they really need to be above the age of 1 and then to 17 years of age. And they have to have either a diagnosis of asthma or have been treated 2 times prior with bronchodilator for wheezing. However, they might present with a first presentation of wheeze and there's a family history of asthma. That's not saying that they can't be prammed. They just need to have a very clear picture that this is asthma and not bronchiolitis. And I would definitely say we are seeing less than 1 year olds getting prammed, and it's just not going to work for them. So they really do need to be greater than that 1 year of age. So what is the Pram score? It's 5 assessment criteria. Again, we're not going to go through this. I think that the policy and the PPO for interior health does a very good job of going through it. But this should be done by ideally with 2 people in the room to agree on it, especially as I don't know if there's any other RTs on here, but for me, when I'm down there, I'm probably going to be with that patient for the acute phase and then I'm leaving. So I definitely want to make sure that whoever is going to be looking after this kid long term agrees with the assessment score. It is a bit of subjective because you have auscultation. So making sure that whoever is going to be looking after this kid long term also auscultates and also agrees on the score, because then we need to make sure that we need to determine if this kid's going to get better or if they're getting worse. Sometimes a silent chest can be determined as no wheeze, but really they're not moving any airway or any air. And as we give them the Ventolin, they're going to open up and we're going to hear a lot more wheeze. That's technically an improvement. So we definitely have to make sure that the person who's looking after this kid is agreeing on the score. A big point to point out here too is that scalene muscle retractions are palpated. You can see here on the pictures, you really need to get in and feel those muscles. And if you haven't felt them before, it's hard to explain, but just you'll know when you feel them. They're not very common. They're only there in about 10% of patients, and they're usually only in the severe presentation. So if you're feeling that, that's already a red flag that they're already on the severe pathway. So classifications of Pram, we have mild, moderate, and severe. Moderate is when it starts to get really tricky, and severe obviously is everybody's worst nightmare. So they should definitely be in a trauma bay with on tele, or not tele, sorry, I guess they should just be on some sort of monitor, making sure that you have ideally a one-to-one nurse for that severe patient. Medication dosing, again, this is all in the PPO. So the weight is 20 kilos, less than 20 kilos, you want to give less medication. Greater than 20 kilos, you're going to give more medication. The mild moderate always get MDI and spacer. The reason being is MDIs give us smaller particles and they actually get a little bit deeper down into the lungs. So even if that kid is screaming and crying and you're holding that aero chamber with the mask on their face, they're still getting a lot of medication. NEBs are if they're on the severe pathway, if they're breathing too fast in order to get the MDIs, or if they require an oxygenation or oxygen, then they would go to the NEBs. The mild, they just get a couple puffs of Ventolin, either 5 or 10, recess. If they're good to go, they go home. Biggest thing with this patient though is the education. So yes, it's one thing to come in for them to treat the asthma and emerge, but they really need to make sure that there's follow-up. The milds, if they're not treated and properly long-term, they're just going to come in again and they're going to be sick. So making sure that we're they're following up with their family physician, that if there's a capability for an asthma clinic, every patient who's seen in Kelowna General Hospital should be ticked off for our asthma clinic. We have an RT who can just even review the puffers for them. But every kid who comes in with asthma should be followed up by somebody and making sure that they're on an inhaled steroid if they need one. Moderate is when it gets a little bit tricky. So what we do for the moderate is it's called back-to-backs. It's Ventolin and Atrovent every 20 minutes times 3 doses. We'll go into the next slide has a bunch of tips on it, so we'll get into it there. But you give Ventolin and Atrovent. Atrovent, you only give within the first hour. So you give Ventolin, Atrovent, Ventolin, Atrovent, Ventolin, Atrovent. There's no evidence to repeat Atrovent after that. So going after there, if they need more medication, it's just Ventolin. Also really important is asthma is inflammation. So what treats asthma is steroid. So you definitely want to get that oral steroid in there as soon as possible. I usually recommend to do it after the first back-to-back. So you have your Ventolin and your Atrovent, the kid's probably screaming, crying, hating their life, and then that's when you give the oral Dex, just to make them even more upset. But you have to get that in as soon as you can. Tips, called back-to-backs, like I said, give the Dex after the first round of back-to-back if possible. Time starts at puff 0. So this is really important. Let's say you started your back-to-backs at 8:20. You've given your 10 puffs of Ventolin, your 6 puffs of Atrovent. Your next round of back-to-back starts at 8:40. So you potentially could be in that room for a long time giving a lot of puffers. And then your next one would be at 9 o'clock. And then after that first hour, you wait 20 minutes after that, reassess. Often they will require either Q30 Ventolin, Q1 Ventolin, and then as they're starting to get better and the Dex starts to kick in, you can stretch that as longer. Any sort of, specifically with asthma, there's a golden hour, but really with any sort of respiratory pediatric illness, there is a golden hour. You have that 1 hour to get all of your interventions in to see if they're going to recover and improve from there. So severe is obviously very, very scary. If you have severe, you want to get a patient into the trauma bay as soon as possible. Sorry, I just needed some water. You definitely want to be giving your Ventolin continuously with oxygen. That's very key. Any child who has nebulizations, it's on oxygen, not air. It needs to be with oxygen. So you're giving your continuous Ventolin. You also need to get your Atrovent in there every 20 minutes. You definitely want to establish IV access. You want to run maintenance fluids. You want to give IV steroids, IV magnesium sulfate. And if that patient deteriorates, you definitely are going to need an IV then. Making sure you're calling your MRP quickly and pediatrician if possible. And remember that BC Children's is always there to help. So if you're in a rural site and you are severe asthmatic comes in, call them immediately. They will be able to walk you through this if you're uncomfortable with doing this. So the dosages for Ventolin get a little bit weird because according to the Pram, if they're greater than 20 kilos, they need to have a higher level of Ventolin, not just the 2.5 milligrams, which we have. I'm not sure if every site has this, but what we have decided to do is there's a high dose Ventolin. So it's 5 milligrams per mil vials. And that's what we use for any weight of our severe asthmatics. So we have stocked that in our trauma rooms. So if a severe asthmatic comes in, we're able to drop that medication, dilute it down so that it's an appropriate fluid for the nebulizer, and then we continue that for Pram less than 8. If you don't have that, and if it's a very confusing thing, just throw in your regular nebs until you're able to pull this up and read it and see what it says. The biggest key is just to make sure that you have some sort of Ventolin going, and then you can read the policy to see what actual dose there needs to be. And a reminder that they definitely need that Atrovent as well. So every 20 minutes, you should be giving the Atrovent nebulizer as well. Okay, so discharge and education, like I said earlier, it's super, super, super important that they are followed up for education. All patients admitted, or really any patient that's in the mild range to the severe range, should have a referral to an asthma clinic. An action plan should be filled out before discharge and emerge, and then basic education about how to use the inhaler properly and when to come back in and seek further care should be done on all patients. On the bottom of the PPO, there is a consider pediatric outpatient follow-up. So as you can see here, there's lots of options to pick. The asthma education clinic is just an RT who even will review just how to use the Ventolin inhaler if that's what they need. Okay, COVID, where does this fit in? So COVID has obviously thrown everybody for a loop now, and how we manage has significantly changed. So COVID-19 presentations, like I said before, it is a coronavirus, which also causes bronchiolitis. So they usually do present like bronchiolitis or asthma if the patient has underlying reactive airways. Omicron seems to be presenting like croup. So when these patients are coming in, they tend to have croup-like symptoms. And again, if they come in having croup-like symptoms, you're just going to treat them as such. You're going to give the Dex, the epi as they need. If they come in with bronchiolitic symptoms, determine if they're mild, moderate, or severe. Do they need hydration? Do they need oxygenation? If they present with asthma-like symptoms, you treat them as an asthmatic. Should we Pram them? And then we give them Ventolin. Is that improving? You just treat whatever symptom they are presenting with. It's quite rare to have true COVID pneumonia in pediatrics. However, it still happens. And again, you would treat them as their symptoms. Do they need high flow? Do they need BiPAP? Do they need higher level of care? They likely are going to need antibiotics at that point. Something that we are seeing in kids is this MIS-C, so multi-system inflammatory syndrome in children. It is a post-viral immune response to COVID-19. It presents with cardiogenic and toxic shock, kind of like a Kawasaki's disease. One of the first ones that presented or was diagnosed in BC was actually in Kelowna, and they were transferred to BC Children's, and I look after them there, and they were quite sick. They did require a lot of fluid, but because they were in cardiogenic shock, they backed up into their lungs, then they required CPAP, they required pressors. They do present quite sick. So if you do suspect this, and you say, get in your history, oh, there was a COVID exposure, and they present with flushed, kind of warm shock, weeping eyes, septic-y type picture, make sure you call BC Children's right away, the telehealth link there, because this patient is probably going to require further level of care. Management, we really talked about, just treat what they are there with. So the studies are very limited in children, mostly following adult guidelines, and a lot of the studies are really for greater than 12 years old. Less than 12 years old, there's limited studies, but treat them as they present. Okay, we're getting close to time, but I do just quickly want to run through oxygen therapy, high flow nasal cannula, and non-invasive, because it is quite different in pediatrics. So oxygen therapy, the maximum flow for pediatric low flow nasal cannula is 4 liters. Anything more than that, they're getting too much oxygen, and we need to escalate care from that. Yes, in adults, we generally go up to 6 liters per minute, but that's not that much oxygen for them. But a 4 liter per minute for a pediatric patient is quite a bit. And keeping in mind, the younger the population, so, the less than 1-year-old, 4 liters is an excessive amount of oxygen for them. I would almost say that 2 liters is too much for them. As soon as they need more than that, you have to consider something else is going on. I need to reassess my patient. Blow-by is an effective temporarily, but is not sustainable long-term. It's not an appropriate oxygenation therapy for them. As soon as the patient moves, the blow-by is going to be moving with them. So unless you have somebody there actively holding it on their face, then that's fine, I guess, but it's not sustainable. A non-rebreather is not a long-term option as well. This is way too much oxygen, and if they are requiring a non-rebreather to keep their oxygen up, something else is wrong and we need to fix the problem. High flow nasal cannula, or the Airvo device. There's been lots of studies about high flow in pediatrics. The biggest one was called the Parish trial down in Australia and New Zealand, and then it eventually did go worldwide. What they studied is it safe to use in a less than 1-year-old bronchiolitic patient to prevent escalation of care of PICU for intubation or non-invasive? Really, the results were yes, and then high flow blew up in the pediatric age range. So now they're doing a Parish 2 trial, which is greater than 1 to 12-year-old, and the preliminary data is essentially saying the same thing. Yes, it's safe to use. So high flow has been approved to use in all pediatric ages. It's really the most evidence is coming from the less than 1 year old. Lots of studies have showed if you start it early, it's preventing escalation of care. Some studies are showing the opposite, that it doesn't really decrease admission stays. So the new PPO that's coming out soon, we'll walk through that when to start it. But really, my guide to start high flow nasal cannula is, do they have an oxygen requirement? That's kind of, they generally need an oxygen requirement to go on high flow. And what's their work of breathing like? Is this work of breathing sustainable? If it's not sustainable, then you can definitely try a high flow to see if it works. The benefits of high flow is it takes your gas exchange, so you have anatomical dead space, technically from your nose to your bronchioles. What high flow is really good at is it washes that out, so every breath is more of an effective ventilation. So it can potentially take that feeling of that air hunger away from the patient and make every breath a very effective breath for ventilation. So that's why it sometimes works in bronchiolitic patients. So it's usually done on the Airvo. I'm not going to get too much into the Airvo about how to use it because I think most sites have it and have probably how-to guidelines on it. But for pediatric patients, you want to start at 2 liters per kilo per minute with a max of 50 liters. And again, this will all be on the high flow documents that are coming out. There's been no evidence to increase past 2 liters per kilo per minute. And also no evidence to start less than that. If you're starting less than that, you're not meeting the inspiratory demand of the patient and you're not going to see those benefits. Really, once you start it, you do not want to disturb. So if you're planning to start Airvo and this kid needs to get blood work, chest x-ray, blah, 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 try and get all of that done first. Bundle the kid up, start the high flow, turn the lights off, put on Cocomelon, Paw Patrol, whatever they like, and let them be. You're not going to know if it's going to be beneficial if the kid is crying and upset. They have to be settled. Escalate from high flow. So if a child has not clinically improved within 1 to 2 hours once settled, or O2 requirements are increasing, the next step would be escalate to non-invasive if you are in a site that is capable of doing that. Really, you always want to avoid intubation on any respiratory pediatric patient. They're often very difficult to manage on a ventilator. They ventilate more of like an ARDS type patient. So we do want to avoid intubation if possible on these patients. Pediatric non-invasive, I recognize that not a lot of sites have this. We are working on trying to increase our resources available for the rural sites, so stay tuned. Non-invasive, like I said, should be, if appropriate, should be trialed before intubation. BC Children's recommends starting at a Delta 5 or a PIP of 10 on 5, so 10 on 5 or Delta 5 on 5, whatever you guys call it. BiPAP is often preferred over CPAP just due to the cause of the respiratory distress. So usually they come in and they have a ventilation failure, and they require that dual level of pressure to help with ventilation. And ideally, an NG should be inserted before to make sure that their belly doesn't blow up with air. If a kid's belly is blowing up with air, you're going to have more troubles with ventilation. Often, too, in the younger age, there is a low dose sedation that is usually required. If you're not in a site that is comfortable with that, again, you can call Charlie, you can call BC Children's, use your resources. But really, if these kids need the BiPAP and they're not tolerating it, low dose sedation is required and often utilized in these patients just so that the BiPAP can do their job. So there is a bunch of pediatric resources. We have the InsideNet shop, which is the new site for BC Children's, all of their policies and procedures. They also have a very good high flow bronchiolitic guideline, which we pretty much copy pasted for Interior Health, which, like I said, should be coming out soon. Canadian Pediatric Society is where I got most of this information from. PDStat is an app that you can get on your phone. And it's essentially the Broslow cart on your phone. You put in the patient's weight and it gives you all the sizes, all the medications. And then Pediatric Respiratory Resources for healthcare providers. I'm scared to open this because it didn't work for me one time, but this is a really good summary of what BC Children's has put out for Croup, asthma, bronchiolitis, and kind of goes over what we talked about today. Questions?
Wow, what a lot of fantastic information, Renee. So does anyone have a question? You can put your hand up. You can put it in the chat. I don't see one, so I'm going to ask one.
Okay.
We just actually received a question from Child Health BC about whether Interior Health had a nurse-initiated asthma protocol for kids. Is that something that's being looked at, Renee?
I don't know the answer to that question, but however, I think that's the goal of the Pram score, is to have it that if a kid comes in through triage, they get Prammed right away, and if they meet the criteria and the Pram score, the nurse is able to start the Pram right away by giving the Dex, giving the puffers, and then it can be followed on. However, I don't know, and the nurses on here probably will know better for that. I believe that the doctor still needs to write orders in order for that to happen according to the PPO, because I think it's still a checkbox, but I don't know. I could be wrong. I know in other provinces it is a nurse and RT initiated protocol though.
Yeah, so certainly some of our other health authorities are using a nurse-initiated protocol. We don't have one within IH, so I just wondered if you knew if something was coming.
No, I would love for that it to be a thing.
While I'm waiting for questions, what do you see are the top 3 or 2 issues that maybe we could focus on? Like, this is such a broad topic.
Yeah, so I think one of the big, I don't want to call it an issue, I think it's just an education point that we can do, is that any kid who comes in through the emerge with any sort of respiratory disease is getting Prammed. And I think that there's a very minute population that needs the Pram and will benefit from it. There's been many cases where a child's getting Pram, they're not improving for 12 hours. They've had 100 puffs of Ventolin, they're not improving, and it's because they have bronchiolitis. And so we've been treating something that we think we are seeing, and it's not actually there, and potentially the kid is getting medication that's unnecessary. So I think really making sure that you're pramming appropriately and that they meet that inclusion criteria is really important. And I also think if we do suspect it's bronchiolitis, there's no benefit to giving puffers if they're not responding to them, especially the Atrovent and the Ventolin. Again, if you're suspecting reactive airway, sure, try Ventolin, but if it's not working, don't repeat it. Making sure that it's very symptom management, starting low flow, high flow when it is necessary.
Thank you.
I'm curious about just kind of a follow-up to that. So I know you had mentioned that when you're trying epi, that if you try it once and it doesn't change, which you would be able to tell by like stride or work of breathing, right? That would be, okay, that's not working. What is that for when we're looking at a Pram score and we're giving Ventolin and Atrovent? Like, is that one dose? And then if that doesn't work, and how do we, in terms of, like you were saying, that assessment piece, if we're not totally sure, maybe it's slightly better, maybe it's not, like what would be the trial failure, if that makes sense, to prevent that kind of, 12 hours of.
Yeah. So are we specifically talking about bronchiolitis or asthma or croup or kind of anything?
I would say that, let's say I don't know what's happening and I hear wheezes and the child is over 1 and there's maybe a family history, like mom uses salbutamol, nobody really knows if they have asthma or not. What would be the trial of Ventolin, and how would I know that it's failed?
That's a good question. It's very case specific. I would say, just going off of what I've seen in the past, if it's true asthma, they do respond and you will notice an improvement. Especially after the back-to-backs. Like, we had a patient a couple weeks ago where she came in, she was Pramming 9, we gave all the back-to-backs, we gave the steroid, and within an hour and a half, she had significantly improved because she had asthma. She had a viral something caused by asthma. It's so tricky. It's such a subjective thing. So if you're giving Ventolin and you're really unsure, you're thinking, you know what, maybe I hear a wheeze, maybe this is bronchiolitis, you've given the Ventolin because you've done a Pram score, let's say, just because you're just trying to figure out what's going on. Let's say the Pram score didn't get better, but maybe looking at the patient, they look like their breathing's a little bit better. maybe you would try it again. Or if their Pram score is improved, then you're like, well, maybe they're getting better. But if you're looking and you're like, they're still lethargic, they're still breathing really heavy, they still don't sound any better, I'm actually just hearing more crackles in general, I'm not going to repeat the Ventolin. And that's not to say that maybe in if they get admitted in 6 hours from now, you're like, I hear wheezes again, let's try giving another Ventolin to see if it makes a difference. It's usually a continuum reassessment of care. I hope that answered it.
Renee, there's a question in the chat. Can you see it from Debbie about a subset of bronchiolitis?
No, I can't see it, unfortunately. I can try and open it. Let me see.
Oh, I can read it for you if that would help.
Sure.
Is there a subset of bronchiolitis with reactive airways who may respond to salbutamol? It does seem that some of these patients improve with beta agonists.
Yeah, and there is. I think if they are responding to bronchodilators, they probably have some sort of underlying reactive airway. And it's very common that a viral infection will exacerbate reactive airways, which is essentially asthma. And that's honest. It's tricky because a big reason why kids come in with asthma is probably because they have some sort of virus to begin with. So if they are responding to Ventolin, and it's probably because they have a reactive airway, and then that would probably be a point to Pram them to see if they're going to get better. And at that point, you're kind of treating two things. I'm treating the bronchiolitis as a virus, but I'm also treating the reactive airway on the side as well. And again, I think really that age less than 1, you'd have to chat with a doctor, but if they're less than 1, they really shouldn't be getting Ventolin unless you do hear that wheeze and there's a family history of it and you've trialed Ventolin and it's working. But I think the biggest take-home point is trial it. If it's not working, don't repeat it. If it does work, then great. You can change your course and see if it's working.
Okay, team, we have a few more minutes. Any other questions? I just had one more.
Sure.
Because I loved that you actually raised this point. Can you talk about what it means to identify a family that's unable to cope?
Yeah, so that's a very good point. So I think we've all seen that mom that comes in that's totally overwhelmed. Maybe they have 3 other sick kids at home. You've determined that they're unable to feed properly. Maybe the mom is very upset, very crying, or dad, I should say, caregiver, whoever is coming in and they're unable to cope. It'd be more, not necessarily a social admit, but definitely a family member unable to cope, you can bring them in. I think if there's other sick kids at home and they're unable to, they've said that my kids are sick at home, I don't know what to do, I'm unable to take care of them. We know that might be a reason for the kid to be admitted into the hospital.
Okay, team, we have 5 minutes left. Any further questions? And we're not afraid to call it now if there aren't any further questions. Okay. Renee, thank you so much again. You're a wealth of information, an incredible resource to interior health. So team, thanks for signing on. We will, Renee has indicated we can share her slides. We'll share the recording and we will also send out an evaluation. So thank you all and have a wonderful afternoon. It looks like the sun is coming out here.
Yeah, hopefully. Hopefully it looks good. Colleen, I will say that there are protocols coming as well. I just saw your point. We have a bronchiolitis and a high flow protocol coming out. So hopefully those would be available soon.
Thanks for seeing that comment, Renee.
Thank you.
All right, you guys. Thanks a lot.
Bye-bye.